Hello and welcome to another edition of the Neuro-Op Guru. I'm here with Dr. Drew Carey from Johns Hopkins. Dr. Carey?
Hey, Annie.
And today we're going to be talking about how even modern high-resolution MRI could miss up to a third of internuclear ophthalmoplegia lesions. And so, Drew, maybe you could just tell us what an INO is and what would that look like clinically?
Absolutely. So an internuclear ophthalmoplegia is caused by a lesion in the medial longitudinal fasciculus, which connects the sixth nerve nucleus and contralateral third nerve subnucleus of the medial rectus. And this is an important structure because it helps maintain lateral gaze. So if you're looking to the left, you need your left eye sixth nerve to innervate your lateral rectus and your right third nerve to innervate the medial rectus. And they have to do it in a coordinated manner so both eyes move at the same time as opposed to one eye and then the other eye, and then you get double vision. If you have a lesion there, oftentimes you see the one eye has an adduction deficit, so it doesn't look well towards the nose, and the other eye moves pretty well, except it has an abducting nystagmus, and it's a very classic appearance. It's not a third nerve palsy. It can be associated with other findings like skew deviation, but it's very well localizing, and depending on your age group, it has very typical causes that we may need to identify because of other neurologic implications of those disease processes.
So by age group, you mean if you're young, you have demyelinating lesion, and if you're old, you have a ischemic lesion?
Yes, that is what I mean. And it's different from our ischemic cranial nerve palsies because this is in the brainstem. So it's a parenchymal ischemia, which means it's a stroke. And while patients may improve with time, if you have a stroke, you're at risk of having further strokes. And so they need stroke modification and assessments to decrease the risk of having further strokes.
And so, what were the results of this study with MRI, with INO?
Yeah. So they looked at the single institution, and they looked at patients who had an INO, and they had to have a MRI imaging on a 1.5 Tesla or 3 Tesla magnet. So these are modern, fairly high resolutions. They had to have good quality scans, less than or equal to 3 mm axial slices, and they were looking for T2 lesion and a newly diagnosed INO patient. And so done at 2 different universities. They had an independent review of all of these MRIs by a neuroradiologist. And they looked at the original reports, and they said that only 64% of them on the original report were able to identify the lesion. When they reviewed them, they did see a T2 hyperintense lesion on 73% of those MRI scans. And in patients with demyelinating disease, they were able to find a lesion of T2 hyperintensity in 76%, but only 24% of them were enhancing, which is a separate but interesting point. And then in the stroke patients, the T2 hyperintense MRI lesions were present in 24%, and they only had diffusion weighted imaging changes in 43%. So,
Yeah. Isn't the
easier to find in
DWI
MS,
supposed
harder to
to
find in a
be,
stroke.
is DWI supposed to be for stroke? Shouldn't you see restricted diffusion, or it's too small?
A lot of times these lesions are really small. And I think that's the problem. And it may not be quite as good in the brainstem because when you get to tissue interfaces, there's a lot of distortion. Like it's really hard to see that in an ischemic optic nerve injury. And you have it's a small area and it's surrounded by cerebrospinal fluid, and then you have the aqueduct there, so you can get a lot of artifacts.
And shouldn't the demyelinating lesion that's acute be enhancing, or same problem?
I think it's the same problem. We'd like to think that the slices are perfectly correlated on your T2 and on your T1 post contrast, but they might not be perfect, and so you may miss it.
And do you admit the INO if it's a stroke, demyelinating, either, both?
I call on my neurology colleagues. I think most of them do get admitted for rapid stroke workup to see what risk factors they have and what we can do to minimize them. Now, granted, if it's a small lesion, most of the time, right, this is hypertensive injury. and small vessel disease. But that doesn't mean they can't also have atrial fibrillation, carotid stenosis, vertebral dissection, embolic disease from cardioembolic etiologies. And so those do need to be evaluated. For the demyelinating patients, it depends on how disabled they are. If they have known demyelinating disease, we definitely need to coordinate with their neurologist to say, hey, they're having active brainstem complications, and that has a really poor long-term prognostic factor. If they're really disabled by it, then we know that megadose or pulse dose IV steroids do help to speed recovery. If it's minimal and they have known disease, they may not need to. If it's a new person and that's their presenting symptom, then usually they're going to end up being admitted. Absolutely.
So what do you think the take-home message for our audience is from this study?
I think the major take-home point is the clinical exam is really crucial in these patients because it's going to tell you where the lesion is and tell you that it's a brainstem parenchymal lesion, and that just because you don't see it on the MRI doesn't mean it's not real and the patient does not have a real disease, and that does not have serious neurologic complications if it's not diagnosed and treated appropriately. So I think all our general ophthalmologists and neuro-ophthalmologists need to, remember that the exam is important and coordinate with our neurology colleagues for the appropriate care of these patients.
And I think we always tell our residents, we treat patients, not those MRI scans. The MRI just confirms what we already think. And if you think it's an INO, we're going to treat it as an INO and work it up as an INO.
Absolutely, yeah. And the MRI can tell us other things, like is it multiple sclerosis, or do they have other silent strokes occurring that, tell you multiple vascular distributions, think about cardioembolic disease. But that specific lesion is a clinical diagnosis, absolutely.
Well, that concludes another edition of the Neuro-Op Guru. Thanks again, Dr. Carey.
Thank you for having me, Dr. Lee.